Alright, so this is going to be the final lecture that I'm doing in the Chapter 21 discussion. You don't have to worry about the area of the text entitled circulatory routes. So the various vessels, where they're branching from, where they're going to, that is not something that you will see on your lecture exam. I think that's better left for your laboratory practical. So we'll leave that for that. But this kind of builds on our whole blood pressure theme that we've been talking about for a couple of different lectures now. And hypertension and shock are kind of the extremes of blood pressure. Hypertension is obviously an elevated blood pressure, typically defined as anybody that has a pressure of greater than 140 systolic or 90 diastolic. And hypotension is usually what's associated with shock. But shock is usually more determined by extreme hypotension. Hypotension to the point where blood is no longer maintaining the flow necessary, and as that flow would begin to decline, obviously nutrients and oxygen would not be delivered to tissues as they should, and based upon that, you can see some abnormalities. So, not going to really talk to you about how you measure blood pressure. If you have to do that clinically, I'm sure they'll tell you about that at some point in time. But you can see we are discussing hypertension because it is a very significant disorder, especially within America. It can cause a variety of different subsequent disorders, heart attacks, heart disease, strokes, and the list can go on from there. Alright, so here's just a quick slide. You have access to this in your Blackboard course site, but it kind of shows you that how we rather break up hypertension. And rather normal blood pressure for most people, and this number is actually being pushed a little bit lower. When this slide was made, the standard numbers were around 120 systolic and around 80 diastolic. But you can see if you were above 120 or 80, anything above that, we are kind of trending a little bit above it. We usually would refer to as pre-hypertensive. So you can see 120 to 139 or 80 to 89. But like I told you before, if you're above 140 systolic or 90 diastolic, at that point we would consider you to be hypertensive. Now, stage 1 hypertensives usually fall into about a 10 millimeter degree of mercury range on either side. So you can see 140 to actually 159, about 20 there, and then 90 to 99. Stage 2 hypertensives, anybody over 160 systolic or greater than 100 diastolic. So your average normal blood pressure for our purposes, we'll say, is around 120 over 80. But anything greater than 140 systolic or 90 diastolic, you definitely are hypertensive. Now, why do we concern ourselves with this? It's because a lot of times the effects of high blood pressure aren't even noticeable. People can walk around and be hypertensive and not even know it. But long term, that higher pressure is doing damage to the small vessels that supply the kidneys, the eyes, the heart, the brain. And if those vessels suffer damage, they try to protect themselves by usually thickening or increasing the thickness of the lining of their lumen. Well, the problem with that is that as the lumen's walls thicken, typically we see less space. And less space within that vessel means that basically you can't cause as much blood to flow through it. So, definitely something that we watch clinically, definitely something that we try to treat aggressively if we need to. Now, usually we break hypertension up into one of two categories. We call it primary versus secondary hypertension. And I don't have a slide that talks to you about that, but I'll just kind of tell you very quickly. Primary hypertension is a situation in which hypertension or high blood pressure is the issue. You don't really know why that person has hypertension, but you know that they have it based upon those physical measurements that are made. Secondary hypertension is hypertension that develops secondarily to something else, meaning that there's another disorder or another issue that's causing a problem, and because of that, that person has high blood pressure. Secondary hypertension can usually be solved if you solve the main issue. But with primary hypertension, like I said, the cause is really unknown. All we know is that you have it, and we try to treat it accordingly. Now, the opposite side of the coin is shock. Shock is caused by extreme hypotension. So when your blood pressure is too low, remember, as I said in the lead into this, you would not be able to maintain adequate flow because there's just not enough force, enough pressure to cause blood to flow. And with hypotension, extreme hypotension, it would ultimately possibly lead to hypoperfusion, meaning because the blood is flowing slowly, you wouldn't perfuse organs with enough blood, and based upon that, organs could enter shock, the organs could begin to fail, and death may ensue. Now, the causes of shock are varied. All you have to do is kind of consider anything that could cause a substantial decrease in blood pressure, and that is what could possibly cause shock. So you see up here the 4 different types of shock. You see hypovolemic shock, which would be due to a decreased blood volume. You can see that in cases where people are bleeding. We usually more specifically call that hemorrhagic shock. You can see it in cases where people lose extreme amounts of fluid or they are extremely dehydrated. So hypovolemic shock means a loss of blood volume to the point where basically you see organs begin to fail. Cardiogenic shock, where the heart is at the root, usually due to, you see it a lot of times obviously in the case of heart attacks, but some people have failing heart muscle. Sometimes the muscle becomes floppy, or what we technically refer to as flaccid. And as that muscle becomes flaccid, you may see cardiogenic shock develop from that. But emphasis here with cardiogenic shock is that the heart is the issue. Obstructive shock is something that occurs when you block off the flow of blood to a given area. It would kind of be what's seen when we look or consider the condition of a pulmonary embolus. The embolus blocks blood vessels leading to the lungs, leading to shock. And then one of the more troubling issues is vascular shock, in which the blood vessels are the issue. Usually this is caused by a massive and very quick vasodilatory event. We see it a lot when we see people who are allergic to bee stings or maybe peanuts or something like that. It's technically anaphylactic shock, but with anaphylactic shock you get widespread vasodilation due to that allergen being introduced. And when those vessels dilate all at once, it can drop the pressure very quickly, and subsequently that person could face a life-threatening emergency. You can also see vascular shock secondary to sepsis, and this is just when an infection spreads into an individual's bloodstream. During that situation, what would happen is one of the reactions that your body has to an infection is to cause vasodilation, and the vessels lead into the area where the infection is occurring. This is because as more blood flows to the area due to the vasodilation, you will get more blood with more white blood cells to help fight off the infection. However, in the case of septic shock, the blood is infected and the vasodilation occurs throughout the entire body, which is not something that should be occurring, and consequently it can decrease the pressure significantly, ultimately leading to shock. Now, the body's response to shock is to try to do anything to increase your blood pressure. So you see a lot of different things all kicking in at once, and you kind of see some of these compensatory mechanisms here. You're going to see your cardiac output attempt to be increased. Why? Because you need to pump more blood out per minute to try and raise that pressure up. So you see an increase in contractility. You see an increase in heart rate, all in an effort to drive that cardiac output up. You see vasoconstriction. Vasoconstriction, the organs where, they're not absolutely vital, like your extremities or some of your internal organs. And you see vasodilation toward the areas where you absolutely must maintain flow, like your brain and your heart and your lungs. You wouldn't see so much of an increase in flow toward, for instance, your fingers or your hands, because they're not absolutely vital for your survival. You're going to have hormones being released, all these hormones that will try to increase your pressure, such as ADH, such as renin, which would make angiotensin II and cause vasoconstriction. Aldosterone, leading to a reabsorption of sodium, which will also allow you to reabsorb more water. All of those hormones getting released are going to try to increase your pressure. And finally, you'll see an inhibition of atrial natriuretic peptide. Remember, that hormone tries to decrease your pressure. So the overall goal here with the body's response to hypotension and therefore shock is to do whatever it can to try and increase your blood pressure. So those are the few comments I want to make about hypertension and shock. Like I said, those are the two extremes as far as abnormal blood pressure is concerned. And with that being said, that's going to conclude the series of lectures here for Chapter 21.